Good morning to everyone. Thank you very much for coming here and join this Global Health Summit promoted and organized by Young Physician Leaders Program and InterAcademy Partnership. We are very glad today to share with you several considerations about leadership and in particular how effective leadership can promote effective health systems. First of all, let me thank you, the InterAcademy Partnership. The InterAcademy Partnership is a partnership of all the Academy of Sciences, of engineers, of public health professionals around the world. It counts more than 30,000 professionals that work around the world for promoting the sciences. And it's very important that one of the pillars of this organization is to promote young leaders. We are here, just here. It's not working, but it's fine. It's not a problem. So it's very important for us to stay here. And we would like to thank our coordinators and the InterAcademy Partnership that promoted among their priority points, building capacity and building effective, this is it. Okay. So it's just the global network of academies of science, medicine, and engineering. It's more than 150 member academies and more than 30,000 leaders, scientists, engineers, and health professionals over the countries. Among their priorities, we know that the first one is to build the capacity of and empower the regional network of academies and their national members. And we are very glad that on the top of these priorities, there is the Young Physician Leaders Program. We are here thanks to this program. There is an annual leadership training course, a side event of World Health Summit, organized with the European School of Management Technology of Berlin. And as young physician leaders, this year, 21 young physician leaders are here to try to share with you how important is leadership and to provide you with global perspectives from us all over the world. So we divided this meeting in 3 sections. The first one is about leadership and leadership experiences. The second one is about women and healthcare, and we will provide you a perspective from young physician leaders. And we would like to share also several inputs related to digital health. What we are doing and try to do is to share our experiences, how we lead our daily job in our countries, and to share with you ideas to promote something that can change our little piece of the world. So I would like to invite on the stage Sarah McGuinness, that is a colleague from Australia, to moderate the first part of the session, leadership and leadership experiences. Thank you, Sarah.
Thank you, Paolo, for that introduction, and guten Morgen to everyone in the audience. So my name's Dr. Sarah McGuinness. I'm a clinician academic from Australia. And as you've heard, I and the rest of this panel are part of a Young Physician Leaders program at this conference. And I feel incredibly grateful to be part of this really dynamic, vibrant group of young physician leaders from around the world and really have the opportunity to share experiences, receive leadership training, and also network with these wonderful people. And in this next phase of the session, really what we want to share with you is some of our reflections on young physician leadership and why it's important, and some of the learnings that we've taken from our leadership training in the last few days. We also want to share some personal leadership stories and experiences and some of the challenges and opportunities that we've faced in our different settings around the world. And finally, some calls to action for the global health community for how we can better engage young people in leadership moving forward. So first, I'd like to invite my colleague, Do-Hwan Kim from South Korea, and I apologize for the misspelling of your name. to really give us an idea of what is young physician leadership and why is it important.
Thank you. Good morning. I'm Do-hwan Kim, a medical educator from South Korea. As one of the IAP Young Physician Leaders, I'd like to briefly share my thoughts on what leadership is and why it is important for us. Recently, I encountered a sentence describing the nature of leaders' work. The sentence may not be the best definition of leadership, but I thought it is highly relevant to young physicians. It is as follows. After all, the leader's task is to get work done through other people. The reason why this quote resonated with me was that it clarified the nature of leadership without any connotation of hierarchy. According to this, what defines someone as a leader is not one's position or seniority, but the task given to the person. Currently, the roles of young physicians are indeed diverse. They are involved in various areas of global health, including patient care, research, education, and public health policy. Just to emphasize, nothing in all of these areas can be achieved with the effort of one single person. This is the first reason why we young physicians should be equipped with leadership skills. Second, we are well aware that leadership is closely related to the performance of a group. Young physicians who are still in their early careers are frequently pushed to perform productively. Moreover, many of the global health challenges we are facing demand strong leadership for immediate and tangible outcomes. Unfortunately, however, one's leadership does not get improved on its own. I'm not trying to say that things like age, seniority, and maturity or experience are meaningless in developing leadership skills. Rather, I'm suggesting that more explicit and deliberate effort to cultivate leadership will accelerate young physicians to become better leaders. Finally, the challenges of leadership in a complex and dynamic environment is to be adaptive to changing situation. We should accept this challenge rather than avoid it. We, young physician leaders, are sharing the responsibility to become change agents and lead social change for better global health. Being young is not and should not be a synonym for lacking leadership. Through proper experience, support, and training, we can become effective leaders as well as contribute to achieve audacious global health goals. Thank you.
Thanks so much, Do-hwan. I'd like to now call on some of our YPLs to share some of their own personal leadership stories, starting with Kosar Asnashari from Iran.
Thank you, dear Sarah. Good morning, everyone. I'm Dr. Kosar Asnashari, an assistant professor of pediatrics at Tehran University of Medical Sciences, Tehran, Iran. And I'm also the Vice Dean for Student and Cultural Affairs at the international campus of my university. In my opinion, physicians can potentially be great leaders in all the systems that they work in their hospitals, in the universities, and on a larger scale, nationally and internationally. The reason behind this, apart from the skills that they can have as leaders and they can acquire as leaders, is what they are expert of, their area of expertise, besides public health and this great encounter that they have with lots of people as patients and the whole society, the whole population as their patients. So now the problem lies in the time management, how to do this, how to make this feasible. What I would suggest was that not to do this simultaneously because, we as physicians all try to prioritize our patients and our job as being a doctor because that's vital. But it's better to put aside some time for leadership rather than just pushing it into our schedules as being a physician. So now this time management thing is much more complicated for women because they have other roles to play. They are wives, they're women, they should be mothers, and they have other roles such as being the daughters of the families. So in some cultures that is very important too, and it brings up many responsibilities. So what I think we have now in the whole society and in the whole world is that the expectance from women has changed. It's not that the society expects them to be less active and to prioritize their other jobs, but this is the expectation of the women themselves. So what I would suggest is for all the women in my country, as well as in all the countries in the whole world, to step forward and to take responsibilities. They can be great decision makers, policy makers, this whole half of the population of the world. And I think in my country, Iran, they can make changes for the better, as well as the whole world.
Thank you so much, Kosar. Now I'd like to introduce Mohammed Atak from Turkey to give his perspectives.
Thank you. Hello, everyone. It's great to see all of you here. I am Dr. Mohammed Atak. I am a physician, a lecturer, and a deputy chief physician at Istanbul University. I have been working in many areas of healthcare, including emergency services, primary healthcare services, and management of healthcare, as well as humanitarian aid and disaster medicine, such as areas influenced by war of disasters. When the COVID-19 pandemic started at the beginning of 2020, I was the district health director of 2 districts in Istanbul with a total population of more than 1 million. We organized and prepared very quickly for this great crisis. We tried to make our struggle with the logic of emergencies management. We have created a crisis center and new workplaces within our district health directorate. We brought the field team together in this area by providing the necessary equipment. We already had a plan for the influenza pandemic, which we created, and we revised this emergency action plan quickly. This plan has made huge contributions to our fight with the pandemic. What we did, firstly, we made intensive training and risk communications studies. We organized surveillance and affiliation studies, logistic and support services studies. We isolate people over 65 years old and or with chronic disease in their home and provided support to meet all their needs by Fidelity Social Support Team. Family physicians played an important role as doorkeepers in this situation. When the vaccines were available, we organized the vaccinations process very quickly, and as a result, we reduced the number of deaths dramatically. This COVID pandemic has took all humanity very important things, as well as physicians. This process, which includes challenges and gains in many aspects, has a wide scope in terms of leadership. I can summarize my experience from the pandemic process as follows. First of all, the field experience is extremely important. Our previous influenza pandemic plan has made our job much easier. Preparation for extraordinary situation is important, I can say. Giving direct and clear introduction to team members about the process makes the job easier. The head of public institutions and organizations, including the district governor, gave me authority with the confidence during the pandemic. Good communication and transparent information were the key elements of this process. And thank you.
Thank you so much, Mohammed. Next, I'd like to hand over to Leonard Lee from the UK to share his experience.
Thanks very much, Sarah. So my name's Dr. Leonard Lee. I'm an academic medical oncologist at the University of Oxford. I lead on our UK COVID cancer programme, and I'm a clinical champion for the immunocompromised and their needs. What is the issue? Well, you've heard a lot about COVID, and Mohammed's made a great talk about COVID. But what this conference is telling us is that COVID is not over. Many of us have mass vaccination in our countries, but infection rates are going up, hospitalization, ITU, and deaths are still high. The issue that I think we need to respond to now is that not everyone responds to coronavirus vaccination. Some people are immunocompromised. They have conditions like cancer, blood cancer, organ transplants, autoimmune disease. They are a minority, but they are young and old, and it can affect anyone. These people can't hug loved ones. They can't see their family. They are still in shielding at 3 years. Their voices go unheard. I'm delighted to talk about our pact. We want to protect these patients with new forms of treatments, antibody therapies. In the UK, we need the leadership to bring together a new consensus, to form bridges and break down silos, to make this pact to protect our vulnerable and immunocompromised, because there are so many. They are a minority, but they are suffering. My team in the UK worked together in a very difficult virtual environment to pull together so many people, parliamentarians, scientists, academics, clinicians, and patient groups. The patients are still in isolation at home, remember. We've got consensus in the UK. 17 medical specialties came together from diverse groups together, with 19 patient charities in their groups, with 4-nation agreements. Over 125 doctors have called for action on this for new drugs like Evusheld in the UK. In this conference, I've been able to have the luxury and privilege of talking to the WHO, and they all agree that we do need to protect people who remain at risk, the vulnerable, the immunocompromised. This will reduce the harms in the pandemic. Leadership is many things, but what I've learned from the IAP is that you need to bring people together to talk. Forging agreements is very hard, but possible. I must be honest, we haven't yet got this project over the line in the UK. We don't have antibody therapies, but 32 other countries have it. Many of the people in this panel have it, but we don't have it in the UK. I'm incredibly grateful for this World Health Summit to be nominated as one of their 21 most outstanding 40-year-olds in the country around the world. But actually, this isn't about me. This is about the immunocompromised and what we do together to protect them. Thank you very much.
Thanks, Leonard. And finally, to share his experience in Sri Lanka, I'd like to introduce Kotsala Weerakoon.
Great. Thank you, Sarah, for inviting. And then I'm Professor Kotsala Weerakoon, a medical parasitologist from Sri Lanka. And let me share my well-focused attempt on improving healthcare over the last decade in my region. The high prevalence in terms of emergence, re-emergence of neglected tropical diseases, particularly leishmaniasis, rickettsial infections, some viral infections, etc. It's a growing problem in my region, remote Sri Lanka. And finding a way out of this complex issue has been one of my foremost goals all throughout. I recognized that need for improved awareness, accurate diagnostics, and human and physical resources as key facets for attention in this regard. Out of all, lack of established accurate diagnostics is one of the critical challenges we have in battling these issues. I believe in detect first, diagnostics for all. And leading this battle was a goal for me. So I mastered basic and advanced diagnostics for tropical diseases with modern techniques within my initial and doctoral studies done overseas. And in parallel, I attempted gradually establishing the diagnostic facilities in my unit. And we are currently in the course of expanding these facilities including serological and molecular diagnostics at my department, Department of Parasitology, Faculty of Medicine, Rajaratnam University of Sri Lanka. And I hope this is going to be a hub for diagnostics in my region as well as for the country to a certain extent. However, the continuous development, progress, and particularly sustainability is a key challenge, mainly with establishing these facilities in non-profit institutions as ours. A pivotal aspect of success in attracting funding support, maybe through linking research grants, one option, and setting up such facilities within established institutions. Initiating these facilities in established institutions invariably carry several bureaucratic administrative challenges, where I needed multifaceted negotiations and discussions onto bottom, top, and laterals. At the moment, we continue with providing basic microscopy-based diagnostics, and further, we utilize these limited resources and facilities for human resource development through regular training of laboratory technicians, and provide continuous guidance assistance for skills development, laboratory troubleshooting, and conduct regular public engagement activities within the region. And these attempts have helped improve the awareness, diagnostics, and improving human and physical resources within the region, and much pleased about what has been achieved so far. Yet, a very long and arduous journey ahead till accomplishing the true goals for us. Emphasizing on detect first, diagnostics for all. When you detect, you explore the need and know where you neglect. Thank you.
Thanks, Pastor. So I think we've heard some inspiring stories of leadership from some of our cohort on their role in advocacy, in COVID, in NTD. I wish we could share stories from our entire cohort because all of their stories are inspiring. But at this conference, I think we've heard about the need to engage young people and the need not just for discussion, but for action. And so I'd like to invite Dr. Susanna Mills to really summarize what are our calls to action as a young physician cohort to the global health community.
My name's Susanna. I'm a public health doctor from the UK. So I hope we've convinced you this morning of the importance of young leadership and the need for 4 key actions for the future. Firstly, give young people leadership opportunities. As we've demonstrated, increasing age does not equal better leadership. We should be more innovative and less constrained with the opportunities that we offer to young people. Secondly, we need more diversity in leadership. We know that people who look like us in terms of appearance, cultural background, previous experiences are far more likely to inspire us to become leaders ourselves. So we really need these people to be front and center. Thirdly, we need greater equity in leadership training opportunities. This might be achieved through effective mentorship, building opportunities into education, and through lifting up those who've been historically ignored. And we indeed acknowledge that we've all been privileged in our leadership opportunities to date in order to be here today. And then finally, we need to develop succession planning. Leaders are only as good as the teams and the leaders that they leave behind. So we all have a responsibility to inspire and to mentor the leaders of the future. Thank you.
Thanks, Susanna. Now, I think we do have a couple of minutes for questions, if there are any questions from the audience. So I see the first hand went up over here.
Hi, my name is Soz, and I'm here on behalf of the International Pharmaceutical Students Federation. And we at IPSF also, try to help out members all over the world with our training and providing as much resources as we can. And we also are huge advocates for interprofessional education. And I know what Susanna Mills' speech was quite inspiring because it sort of resonated with what we try to stand for. And I was wondering, as YPL, what you guys do towards maybe working towards like further interprofessional education, and also, you know, helping promoting other people in healthcare and working together to sort of deconstruct the traditional hierarchies that are there.
Thank you. Excellent question. Is there anyone on the panel? Leonard?
I take that. What defines us as young leaders? I think it is our interconnectedness. We are digitally connecting to people at pace and at scale, and we are reaching out from the top of the organization right to the very bottom. We are nodes, and I think that's really what's happening here at the moment. So that's why I'm able to connect so many people to protect the immunocompromised and shift public opinion to follow the science very quickly. And likewise, you've seen the same being done in Istanbul, South Korea, Tehran. That is a strength of young leaders, and actually that's what the IAP has been showing us. Connecting people, build bridges, break down silos. That's actually what we're trying to do here. But we stand on the shoulders of giants, and we do need giants to help us every so often.
Thank you. Question over there.
Thank you very much. I sincerely appreciate our panelists. I wish I had that opportunity 25 years ago. So I think you are really opportune because one factor and then one call for action to add to Suzanne. Decisions are based on good science and data, but results and outcome are based on good leadership. And therefore, we cannot underestimate the role of leadership in the work we do. Therefore, my call to action is, can we start to invest at pre-service level? Not when we finish medical school. Most of our leadership training, we acquire it either by mistakes or we acquire it as we grow. But I sincerely believe if we want to make a scale change, we should go back to pre-service curriculum and start training people leadership while they are still in school, and not looking at leadership as mutually exclusive of clinical work and leadership as a different role. I don't think that is the right way to go. So investing in the pre-service curriculum could be the way out if we need to go to scale. Thank you.
Thank you for that. Thank you for that excellent comment, and I fully agree that we should embed leadership training in our education programs, and that has to happen before we get put in leadership roles. Thank you. I think in the interest of time, we possibly have time for one more question. I saw a hand over there. And then in fairness, we should give the stage to the rest of our cohort.
Good afternoon, everyone. Thank you to the panelists. I am Fatmata Kasama from the Gambia. I'm not a medical doctor, but I'm a nurse. I serve as the former vice president for the National Association of Gambia Nurses and Midwives, and we work close in hand with the Gambia Resident Doctors Association. And I could see the leadership capacity and the talents they have. So I have two questions. Is the Young Physician Leadership Program open to physicians in developing countries? And the second question is, how can Gambian physicians be part of this leadership program? Thank you.
Wonderful question.
I mean, we've got an expert in the audience in terms of Feels you to say very much open to developing countries. That I think that's part of the target, is to integrate us all together in terms of our range of different experiences. The lady in the front row is probably the one to speak to in terms of how to facilitate individual opportunities with different countries. Would that be a fair? Yeah. Okay. So you got your connection there.
The meeting. Yeah. So in the interest of time, I'm going to hand over to Paolo. Thank you very much for listening to us. And I would also like to just put in a call personally for greater representativeness of my region, of the Asia Pacific region of Oceania at these meetings, because I do feel that we are sometimes underrepresented. So thank you.
Thank you very much to Sarah and the other colleagues. I think that has been a very interesting session because we understood and we tried to explain how leadership can shape the experiences and how experiences from all over the world can shape a good leadership, how we can be effective and how we can define the path to change in a better way our piece of the world. So I think that the first session has been very, very interesting. Thank you. Thank you to all the friends and colleagues of the first session. So the second one will be about women leaders. So basically, we are going to introduce two different aspects. The first one is the women leaders. The second one is the digital health. And the first one about how we have to face inequalities, starting from the gender gap, starting from the gender inequalities. So we have to close the gap, we have to discuss, we have to talk and to act for women health. So I want to introduce my colleague Zineb Edzaitouni from Netherlands, that will be the moderator of this session. Please, Zineb, thank you very much.
Thank you for the introduction. Good morning, everyone. My name is Dr. Zineb Edzaitouni. I'm a medical resident in the Netherlands. And I have the absolute pleasure to moderate this session, which will be about women and healthcare. So for centuries now, men and women have been fighting for equal rights and treatment for and of women. From Jane Austen, the suffragette movement, to the women's uprising in the 60s and 70s, women's emancipation has been an ongoing process. Even though we live in 2022, we are not there yet. Around the world, more and more women make up the health workforce. However, we are behind in fulfilling leadership roles in healthcare. Furthermore, women and those who identify as women still have difficulties accessing public health services and services such as reproductive and sexual health services. Moreover, several studies have shown that medicine is biased towards women and minorities. Furthermore, a recent New England Journal of Medicine opinion piece has been advocating for a more female approach in healthcare. During this session, we give the stage to several panelists who have, in their own way and capacity, been advocating for equality for women in healthcare. Now, before I introduce our first panelist, I would like to ask you all, the audience, to really ask themselves, what does equality mean to me? Do we really need more women in healthcare? Do we really need more women in leadership roles? And if yes, how would we achieve that? I hope this session will give answer to one of these questions. So it is my immense honor to introduce to you our first panelist. She's a junior medical doctor and a journalist. She's a true trailblazer in her country, advocating for youth reproductive and mental health rights. Furthermore, she's a founding member of the Palestinian Women in Surgery Society and an ambassador for the Palestine Academy for Science and Technology. Today, she will give her insights on giving healthcare to marginalized communities. Ladies and gentlemen, Dr. Duha Shella from Nablus, Palestine.
Thank you, Zainab. I am Dr. Duha Shella, freshly graduated medical doctor and journalist from Palestine. But before I start my talk, actually, I would love to thank the team of young physician leaders because I was chosen to represent Palestine. But unfortunately, to enter this room and to enter this summit, I applied as another country, which is my beloved Jordan. But unfortunately, I'm not working in the health system of Jordan. I'm working in the health system of Palestine, aka occupied Palestinian territories. So let's start. So actually my journey with advocacy in sexual and health and rights for the Palestinian women started at the pandemic, where I've chosen to go with the mobile clinics to go to area where we called it Area C. At Area C, we have underserved communities of Palestinians, around 300,000 of Palestinians living there, and they don't have the ability to access healthcare. I went with mobile clinics, which were supervised by the Palestinian Medical Relief Society and UNFPA, mainly supervising these clinics. And my work was to educate women and young females on sexual and reproductive health and rights. And that experience really actually has really affected me, as when I started to see this community, when I was living in a city and I never thought that I would have or meet these Palestinians who are living under these conditions, underserved. They are isolated. They don't have the right to build schools, to build healthcare clinics, and they also don't have the right to access it. So our work mainly was to provide them with the needed information and on sexual and reproductive health and rights, and to hear them and to hear about all their concerns and the questions regarding this aspect of health. And I think this room full of females and full of women who knows how much we need this little information, and it's impacting our life. So and we can also see the need of these clinics and how it's important, because according to the last report of UNFPA, 60% of the breast cancer cases, and now we are in October, that in Palestine are found at late stage, which reducing their chance of survival. And here we can highlight the importance of such clinics reaching humans in these areas where they can at least detect them at earlier stages, so we can save their lives. And absolutely, there is many other examples that maybe the time will not allow us to mention a lot of them. And also in these services, we not just worked on sexual and reproductive health and rights and to support young women and to hear their concerns, also on mental health services. Also, these communities are underserved in these health aspects. And also, we have a photo. Maybe I want to, in the slide. Trying. Yeah, if you can have it. Actually, it would explain a lot of what I'm talking about. And also these mobile clinics, absolutely, beside the sexual and reproductive health and rights and mental health services, mainly they provide primary health care. And I want you to see one of the clinics that we have in Hebron area.
We seem to have a technical glitch, but
it's fine. Maybe we share it later. And also, as youth, we tried to help these communities as we can, as we saw ourselves as much privileged than them. So we developed an app, which is Mustashari. We named it Mustashari in Arabic, which is in English mean consultant. They can go and ask whatever they have questions in a private way, and they been answered by specialists. And also we have created some games for them, so we can reach them in a more beloved way to them and be more close to them, so we can have that connection to them more easy, and to provide them with this information on really serious topic, especially in my community, that it's not we are not allowed to talk about it so much. Thank you.
Thank you, Dr. Scheller, for giving insights in this beautiful project of yours. So all over the globe, the access to women's health services is under pressure. The pandemic showed enormous spikes of gender-based violence, mainly against women. How are we going to guarantee health services access to all women? Our next panelist has an important voice with respect to women's reproductive and sexual health rights. She's a full professor and the head of global surgery, the head of the global surgery division at the University of Cape Town, and is the vice president of the Women in Global Health South Africa. I would like to give the floor to Dr. Salome Maswime from Cape Town, South Africa.
Mm-hmm. Thank you so much. And I'd like to start off by saying that when it comes to women's health, it's not about us and them. It's about us, for us as women. So I speak as an obstetrician and also someone who's now involved in global health to say that I see this as on three layers. As one who has who's been on the receiving end, as a reproductive aged woman on the receiving end of healthcare in various countries, some with better healthcare systems than others, but also I've been in places where I've been worried about the level of healthcare that I can receive as a person, because I'm at the mercy of what is available there. I speak as a women clinician who has been delivering healthcare services for many years, including the 10 years that I spent in the biggest maternity institution in Africa. And I also speak as a leader and influencer who's able to influence policy. As I said, it's not about us and them, it's about us as women and what healthcare service looks like for all of us. So we know there's a huge unmet need for contraception. It's hardly ever stated. We don't talk about it enough, but we know that access to contraception is a big problem. There is a big problem as well with access to fertility services, particularly in low and middle income countries, and we don't do enough to provide services for women. We've got the highest level of cervical cancer and breast cancer rates in Africa and in many LMICs. These are all preventable conditions, and yet they continue to thrive under our health systems. We've got the highest mortality rates, maternal mortality rates in Asia and in Africa. We've got the highest cesarean section complication rates. So we're able to have women having cesarean sections, but women die in our hands because we're not able to provide the services that they need. We've got high levels of gender-based violence. So this moves into trauma, into violence, into orthopedics, into surgery, and all the other fields. Again, this is preventable. And we've got issues that we shouldn't be seeing in this day and age. Fistulas, female genital mutilation, thriving still in many countries. I want to say that many of these things are preventable. There's a lot that we can do to prevent it, only if we take women more seriously in our countries.
Thank you, Dr. Maswime, for breaking down the difficulties women face in South Africa. As I've mentioned before, the fight for equal rights for women entails not only their access to healthcare, but also in the workplace. How are we doing today, and what can we improve? What can we do to improve female representation? To kick off our second half of this session, I give the floor to the only male of the panel that also says something. He is a proponent of the He for She movement. He is a surgeon and a joint PhD fellow at the University of Makerere in Uganda and a human repair neurosurgery department in Ghent, Belgium. Please welcome Dr. Hervé Lekuya from Kampala, Uganda.
Thank you, Zened, for the opportunity. First of all, I'm excited to be part of the team. That's my message, actually. It's shown by the number we see here. It means how many males are joining a female or the community when it's about fighting. Now the question is about where are we? What's the state? What the progress? What is happening? It's a difficult question to give because we can't have accurate way or to assess the progress of the women involvement in healthcare. But looking back to maybe 25 years ago and now, we can be pretty sure that there is a bit of change that we should acknowledge in that part. In the beginning, it was mainly problem solved by women. I think the next slide, if you can show it, it's a bit funny, but that's how the perception is. Let me see the next slide.
I'm trying to.
Oh, it's okay. I was just showing like the heaviness of this fight, how that's what you can understand. The heaviness of this fight is only the female alone, carrying all the fight alone and trying to struggle to reach. And one male looking at them, they say, hey, continue going, moving, it's okay. Then it's actually nothing to achieve. So the next point, when males start understanding the concept and then they start joining the fight, I think that's where we saw some trends by implementing some policy, maybe focusing on number. We want maybe equal number, and then we see some change in terms of recruitment in women in the healthcare system, but also it's more of a quantitative change that we have. But when you look at inside and look at the quantity or the quality, I mean, when you get more women in the system, how are they doing in the system? We see that they just stay down, they don't reach the leadership position. And that's something like everyone sees as normal, maybe traditionally thinking this is how it's supposed to be, but that's not right. And the second thing is also to look at this fact as a trend of development or career growth for women. That's something important to make the change. And my talk, I think, is not too much. It's just to give a lot, to call you to join the fight together. And then, as she say, he for she campaign, it's still applied for everyone. And I hope we join the fight and then not be just looking at the numbers, but the quality of what we're achieving. Thank you.
Thank you, Dr. Lukuya. Just to be sure, we are not as women trying to take over the world. Maybe someday, but it's very important to join forces, to work together. Maybe someday a female king. So our next panelist will elaborate more on the difficulties women face in the workplace. She will talk more about her own experiences, her own views on that. As she's a primary care physician, she is specialized in infectious diseases with a focus on HIV and tropical medicine. I would like to give the floor to Dr. Milagro Sanchez Cunto from Buenos Aires, Argentina.
Well, hi, everyone. I'm very glad to be here. Thank you for the opportunity. As all we know, in many countries, as in the Latin American ones where I came, women represents more than 70% of paid healthcare workers. Despite this, we are underrepresented in decision-making positions in health systems. These inequalities in leadership are due to stereotyping, discrimination, and power imbalances. In addition, we earn on average, I refer women working in healthcare settings, earn on average 20% less than a man who develop the same job. Besides, men are more likely to join or to form a union to defend their rights. The second shift is, I don't know if you are familiarized with the term, but it's a workload of those who work to earn money, but they are responsible also for domestic labor, unpaid domestic labor. And it's not a minor factor among women, and it's very prevalent in Latin America. It's underestimated, as I said, it's unpaid. Sorry. These inequality gaps have become deeper with the pandemics, as there were demanding working conditions, highly demanding working conditions. And these inequalities compromises also the opportunities for us to go up the job ladder. So I think it's very important to raise awareness of this situation, to make these situations visible. But I think as a young physician, it's time to pass from awareness to action. It's important. It's important to make policies, programs, and projects with gender perspective, to make these policies knowing women's necessities, needs in recruitment, in worker retention, and also in career development. I think it's time to get a transformational change. It's time to have an equal health system, and we can't pretend better quality health system, healthcare, if we can have better and fairer working conditions. Well, thank you. I want to, sorry. I want to share some words of Rosa Luxemburgo. I don't know if my slide may be shared, please. Well, if not, you can Google that. Go and Google the phrase. Thank you.
Yes, it's over there. Yeah. So thank you, Dr. Sanchez, for giving your views on equal workplaces. So now we move from identifying problems women face in the workplace to potential solutions. And I want to come back to the lady who actually had a very good comment and question about, okay, so it's really nice to talk about this, but how are we going to move from this point to actually getting better conditions for women? So how can we as a society assist women in becoming leaders in their own communities? Well, our next speaker has some insights on how to do that. She's an associate professor of medical microbiology and a consultant clinical microbiologist. Furthermore, she's a member of the International Society for Infectious Diseases Council. Please welcome Dr. Nadia Attia from Kuala Lumpur, Malaysia.
Hi, everyone. It's really great to be here. So thank you, Zinab, for the very kind introduction. So I think I just wanted to expand and add on to what Dr. Lakuya and Dr. Sanchez had already mentioned. So in many countries around the world, especially in low and middle income countries, female physicians remain underrepresented in academic medicine, especially in senior leadership positions. And this has been shown to have negative implications, not only for patient care, but also for educational outcomes, especially in my country. So based on my own personal experience and from the perspective of a young physician leader, mentoring, I think is one of the key tools to overcome the huge barriers that young female physicians in academia face when it comes to career advancement. Mentoring is very useful because it supports the personal growth and professional development of young female physicians by opening doors and creating networking opportunities for them so that they can reach their full potential in their careers. Unfortunately, studies have shown that female physicians are less likely to have mentors, especially good mentors, despite the proven benefits of mentorship for career advancement. So I think it's very important that universities and academic medical centers make mentoring female physicians an integral part of their culture. There should be formal mentoring programs that cater specifically to the needs of young female physicians, as this would improve the promotion and retention of women faculty. The lack of female physicians in senior academic positions might be a challenge and might limit the mentor pool for junior female academics, but I don't think this should hinder the development and implementation of such mentorship programs. Universities and academic medical centers should encourage both their male and female physicians to mentor the junior female academics. So it's very important that we encourage more male physicians to join our cause, champion this, like what Dr. Lakuya, who's part of our panel, is doing today. Something else that I would like to bring up as well is that young female physicians should also actively seek out good mentors. And if you achieve success in your career, go on to mentor others. I think this is very important. Keep the positive cycle going. Mentoring is definitely an important component of effective leadership, as it brings the best out of the people you lead. I personally have greatly benefited from the guidance and mentorship that I received from my senior colleagues and professors at my university. And I wouldn't be here today in Berlin, be part of the IAP YPL program and be able to attend the World Health Summit if not for the mentorship I received early on in my career. Thank you very much.
So thank you to all the panelists for their incredible contributions. it honestly gives me hope that so many people are here. I think we are fighting the same fight. I think we have the same values. I think we acknowledge that the contribution of women in healthcare and as leaders is very important. And I always say, if they don't give a seat at the table, we just build our own chair and just sit at that table. So I see we have a few minutes left for questions. I can't imagine. Yeah, I already see some hands. So you, sir. Yeah.
Thank you very much. I'm Dr. Zomo, Deputy Minister of Health in South Africa. I would like to really commend all the speakers who have come in here and actually given us what they've given us. But I'll leave you with a story. It's a true story. In one region, heads of states were meeting and they were planning to really discuss agendas of health and other issues in their countries. So they had one leader stood up and said, can we rearrange the issues of the agenda? This item, maternal outcomes in our region, is not my priority. I would like this to be discussed tomorrow when I'll be gone out of the meeting. It had to take another great leader in that meeting to say, we are fighting maternal outcomes in our countries. You have to prioritize. You are here fortunate as a president because there's a particular woman who cared for you. Now, there are other women out there who are struggling to have good maternal outcomes, and they'll never ever be able to produce presidents. So we will leave with the agenda item as is. So we need to educate our politicians, our heads of states, that until and unless we really put maternal issues on the top of the agenda, women's health, there's no nation, there's no country, there's no world. Thank you very much.
I see the gentleman in the red. Yeah.
Obinna Prince Onhara. I come from Nigeria and I'm studying international health management here. I thank you for calling me up to continue from where he started, because we have been talking about this and it happens in a lot of developing countries. Okay, like mine, I will also continue with a story. Now, there is this mentality in a certain place I come from that women are not so much regarded, and it comes from our forefathers. Now, this mentality has gone to the extent that if you are a woman, you don't even have right to things in your family. Now you look at it, the young generation are taking over with this mentality. Now, I want to say, with what Dr. Lekuya is doing, is it not possible for us to introduce his organization into the academia? This is not just about our politicians, but our future leaders that are coming up. If we continue growing with this mentality, I think we can't continue with campaigns. Let us go into education. That is the new ones that are being given birth. We continue teaching them that this mentality is wrong. This is my contribution. Thank you.
Thank you. I wholeheartedly support that. Yeah. I have 1 minute left. So one question. Oh God. The woman in the back, and for the others, we will have the discussion afterwards, if you don't mind. Yeah. You, yeah.
Thank you. My name is Vanya Kibui. I work with AMREF based in Kenya, and I speak as a lawyer who's been working with doctors for a while. And I think the thing that's missing for me in this conversation, the next, is what mechanism are we going to put in place that makes health governance representative? Because everybody's story has come at the end of the line, right? So my experience as should I call myself a reproductive health activist, is we are wiping the floor and the taps are still on. And we keep doing that. And I've done that for, this is close to what? Almost 15 years. And we've made progress, but it's still a matter of life and death for a lot of women. And I think the transformation here is on a few ways, and maybe some suggestions from the room would be great. I think one, what my colleague proposed in terms of in-school training, but then there needs to be that access and community health conversation, because every one of you works in a facility. And so there's an assumption that a lot of our people can access a facility. If we look at the distribution of healthcare workers to community members, it's what? In some places, 0.5, and there's no 0.5 healthcare worker to 1. So they almost never interact with a healthcare worker. So for us, we invest as AMREF in community health systems like community health workers and volunteers. So I don't know what proposals or what strategies you're also using in your countries to bridge that gap so that healthcare workers also are seen as members of the community and not part of healthcare facilities, right? And then when it comes to women and young people, the conversation of who women are and who young people are happens even before the doctor walks into the room. And so the power dynamics are even existent even when me coming from the street walking to the facility is dealing with a healthcare worker. So especially in contexts where the truth holder are two people. If it's not your religious leader or your doctor, you don't believe what they said. So then what can we still go into the community so that then the policies reflected in healthcare facilities, in health systems at ministry level are reflective of people's experiences, because we will make decisions on what, even when it comes to the One Health action and all of that. This is great language for our policies, but it still doesn't make a difference for the life and well-being of somebody if it's not reflective. So I don't know, I've been grappling with that in a lot of the sessions, and I thought I saw young people in this session and young physicians, and I feel like there's an opportunity to bridge that gap. And thank you for giving me your last minute.
Yes, thank you. I think very, very valuable questions and remarks. So I'm going to give the floor to Paolo again.
Thank you very much. And the other colleagues for this amazing session. I think that we go in depth with a very important argument, and we understood how important it is to change and innovate models, facilities, but especially it's so important to pass from the awareness to the action. Now we are going to spend the last session, the third one, focusing on a very important topic that is not only an instrument, but also something that is changing our relationship, our way of living, our professionality. And this is quite important today to talk about digital health and how we can use the interconnection that digital can create. So I'm so happy to introduce my colleague, the moderator, Dr. I would like to say in the correct way your surnames, that is quite difficult for me. Darshika Wickramasinghe. I hope that I...
Thank you, Paolo. Thank you very much.
Darshita, it's a pleasure for me to introduce you as moderator. And please, I'm quite sure that will be an amazing session like the other two that we already carried on. Thank you very much, Ashika. Please.
Thank you, Paolo, for the introduction. Good morning, ladies and gentlemen. We saved the best for last. So welcome to the session on technology and health. I'm Dakshita. I'm an academic surgeon from Sri Lanka. And with me, I have 5 young physicians who are both passionate about the role of technology in health and who are firm believers that physicians have much bigger roles and responsibility when it comes to digital health. So from your left to right, we have Louis Kroon, research clinician from South Africa. We have Bharat Kola, who's an assistant professor in psychiatry in India. We have Flavia Garces, a geriatrician from Brazil. And we have Samuel Noos, a clinician scientist from Germany. And our 5th member is Andrew Gonzalez, a surgeon from USA, who will join us digitally, like the session goes. So when we talk about health and health data, we actually between a rock and a hard place. We want other health physicians to have access to our data, but at the same time, we don't want our data to get into the wrong hands. Louise, as a clinician and a researcher, what's your experience?
Thank you, Dakshi. And I'd just like to use this opportunity to thank the IAP for being here, as well as the South African Medical Research Council and the EDCTP for their contribution towards my journey to becoming a clinician scientist. And yes, you raise a valid point. And I think we as young clinician leaders find ourselves in this era of a rapid digital health revolution. And so today's world of complex large data looks vastly different to years ago, when perhaps the most digital instrument was a glucometer to measure blood glucose levels. There are multiple transformative actions which are required for appropriate data generation, sharing, stewardship, and utilization. COVID has highlighted how we are unable to act in silos and the ultimate value of rapid data sharing for technological advances. As a young researcher in a developing country, I often find myself stuck within the complexity of the system. On the one hand, you want to fast-track data sharing to contribute to processes needed for development. And on the other, you are the gatekeeper who needs to ensure that all of this occurs within well-defined governance, especially with regards to vulnerable populations. This is, of course, also the area which often delays the sharing of data, especially data of a more sensitive nature, like in genomics. And it brings me to my second point, the development and advocacy for the collection of representative data. So this is on multiple levels: age, gender, different ancestries, to name a few. When we look, for example, at Africa, we know that African ancestries are genetically diverse. Due to specific ancestries being exposed to certain environments and pathogens, certain population-specific disease risk alleles can be associated with specific disease phenotypes. In other words, we cannot apply copy-paste models and use European-based data and genomic databases to predict diseases in African population groups. Great strides towards this is being made in South Africa, where this need has been recognized and increasingly more research is being done to include historically underrepresented groups. But more work needs to be done. We need to keep advocating for this until all groups are able to benefit from genetic and technological advances. Thank you.
Thank you, Eloise. I think that's a great start to talk about data. And an important aspect of data is to ensure that it's representative of what we want to measure. And when it comes to healthcare data, that means we need data representative of the whole world. We all heard yesterday Dr. Tim Ferriss talk about how technology can address health inequality. Bharat, in your current practice, do you think this is reflected?
Thanks, Dakshita. I mean, I think you raise a valid point, representative data, right? So we are actually a pivotal moment in global health, because the pandemic has exposed the health inequalities, the digital and the health divide between the have and have-nots. And I think we all agree that there is a clear diversity problem in large global data sets, especially those which are technologically intensive, because the technologies doesn't exist in all the places. Example, genomics data, right? And the imaging data. Today, less than 5% of genome-wide association studies are done on non-European populations, right? So these are it's hardly representative. Mind you, these data sets have a tremendous potential in supporting disease prevention and even promoting larger preventative health efforts, individual level and also at the level of population scale. And if these insights that come from non-representative data are applied, then it is only going to worsen the already existing health disparities, right? So, clearly, I mean, better investment, sustainable investment should solve everything, right? So, but also there is, I see there is a cause for concern. Even in countries where there is reasonably good funding mechanisms for health, you see that there is data diversity problem. So this is a cause for concern, right? So there needs to be stronger dedicated research that collects data into analyzing the root cause of non-representation. Right? So, why do minorities, socioeconomically disadvantaged communities don't participate in the research? Of course, there also have to be deeper and more meaningful community engagement, which are based on equitable partnerships between the communities at hand and also the researchers. So trust, as you know, takes time to build, but it goes away very easily. And once it is lost, it takes a lot more time to rebuild again. So what we need is transparent data systems that protects sensitive health information, but also makes it available for healthcare research and healthcare delivery. So, and not all countries are at the same level of data governance, or the regulatory environment are weak in most places. So there are obviously genuine concerns of data sovereignty that exist and that cannot be ignored. So access to technology is the key, right, to promoting inclusive, equitable, and sustainable digital transformation for low and middle income countries. India's mental health survey in 2016 said there are 85% treatment gap for mental health issues. And cut across the pandemic, this treatment gap is only going to increase. So just last week on the World Mental Health Day, Government of India launched a tele-mental health program national-wide called as the Telemanas, which is hoping to bridge this gap somewhere in the future. I also know India is home to around 400 million young children and adolescents, right? You heard me right. 400 children and young people, adolescents live in India, more than the entire population of the US, two times the Western European population. So studying the risk and resilience factors, we really need to focus on the adolescent mental health. Otherwise, we are only going to worsen the treatment gap for mental health issues in India going forward. So each country has to prioritize their own needs, but global partnership is critical, right? For example, ICMR, the Indian Council of Medical Research, launched a national-wide program to look at exactly this in partnership with the Medical Research Council of UK. So there has to be a global partnership. So to summarize, to solve the digital inequity and to allow and to promote access to technology, we need to address all the 5 Ps that we learned in the inaugural, the Virchow Prize winners, Dr. John's talk. The 5 Ps are: identify the root cause, the problem of non-representativeness, collect data to understand that. Each population have their own unique challenges that has to be addressed with community engagement. Policies that are based on trust and transparency are needed, right? So, and then of course, political will, strong political will that takes it forward. And last importantly, global partnerships are important to address all of these, right?
Thank you, Bharat. From that introduction to this technology, I'd like to nudge this discussion towards solutions, but the ways we'd like to move forward. As physicians, we all agree that we need to get more involved with digital health. And for some of us, that means we need a better understanding of technology. Like cultural capital and social capital, I think the new buzzword is going to be digital capital. Flavia, what are your thoughts about digital literacy among physicians?
Thank you, Lakshita. First of all, I would just add something to what he said at the end. I'm not here, not even trying to provide solutions. Bear in mind that I'm speaking from a non-expert point of view. I'm just a geriatrician and professor who's very interested in digital health. So in my reflections, seeing patients day by day and interacting with students, maybe I can just try to throw out some ideas and get some response in this regard. Maybe we have experts here in the audience, but I'm speaking from a position where in which I really want to learn more about this. That's why I'm a digital health worker whose literacy is questionable at this time point at the level I would want it to be. So that's why I'm here to speak more about this point of view. So we know that the digital health literacy encompasses both the access and the use of healthcare information, that's from the provider point of view, and also in a simple way as a self-care resource for patients. And we have this interface, that's the patient-provider interaction. So we have many avenues to explore in this regard. As the point of view of a physician, we are, as young physicians, in a generation of being using digital resources in a heavy way. I mean, we have been using them, not always in the most productive way. And even though we actually know how to use social media resources, as my colleague Leonard was speaking earlier, we sometimes don't have the digital health literacy in the level we need to accomplish our projects. So for those kind of things, we need multidisciplinary work, multidisciplinary knowledge, sometimes in computer sciences, in management, in business. That's why I appreciate this program, the Young Physician Leaders Program, so much, because I actually got interested in management and business, which was something I would never dream of being interested on, I mean, a few years ago. And we need this to implement digital solutions in the near future. We know how to access this digital information, but we need more to build this new innovation in digital health. So where are the resources, where we can find them? Someone was talking about basic education, like including leadership in the curriculum. We need this also in medical school, or maybe as something very near to us. I mean, to try to learn about digital health in medical school. We have to update this kind of educational basis, you know. We have in our table, he will speak after me, Samuel, Dr. Knaus. He has a very interesting experience on how to, as in a position of a physician, how we can achieve, how we can get inside the world of information technology, of management and business, and implement something real, something that really impacts our patients, our communities. And as the point of view of the patients and the communities themselves, we know that we have vulnerable populations. In my country, I'm a geriatrician, so I deal with older adults at all times. Many of them are very connected to digital information. I would say most of them, those who have the cognitive capability of doing so. But we also need ways of getting to those older adults who refuse to get on these kind of interactions of digital health. We have their families to reach on as well. And in my country, a very specific problem of maybe most of the developing countries, that it's low educational attainment. So I'm not talking about digital communication, about patients being able of understanding digital communication. I'm talking of sometimes not understanding communication, you know, itself. Like we have to try and translate our words in the easiest way possible for them to understand. It's not worth to say something and not being understood. There's no point in this. So we have to align those needs, the needs and capabilities of our patients, and connect them with clinical care, with the usefulness in clinical care, and with our knowledge. That's our role as health providers. This is the unique perspective that we have from both sides of the patients, their needs and capabilities, and also the needs of clinical care. So this is why I believe that digital health literacy should be a goal for each of us, especially those as myself who are more curious than an expert in the topic, and maybe starting from here, from today, to develop something innovative, adaptive to our specific populations, and to impact clinical care in the most favorable way possible. Thank you very much.
Thank you, Flavia. Listening to the three of you, it looks like the future physicians are going to have multiple contrasting roles in the involvement with technology. Sam, you're a developer. You developed and launched multiple digital products successfully. How do you think physicians can contribute more to this development process?
Yeah, thank you. And first of all, I want to contradict Flavia of saying you're not an expert, because I think as a physician, you are an expert. And I want to ask the question and come back to the topic of this session. Why do we need physician leaders, or how can we have effective physician leaders, and expand also this term to maybe provider leaders, to not only talk about physicians as this specific work group. And you could say, well, let the cobbler stick to his last, and physician, that's basically an apprentice job. They should treat patients. That's what we're good at, and becoming a very good physician is a life achievement in itself. But then I want to also look back at the beginning of this conference at the Virchow Prize, and look at the history of Virchow, who was really a young physician leader. He had the first description of leukemia at the age of in his mid-20s. He wrote the Omnicellular Acellular, the defining of the cellular theory, before he was 40, so he could well be here on the panel. But he was also a politician and a social, revolutionized a lot of the social aspects and how we deal with public health, but also how we deal within our society. And remained being a physician and being active in care and in medical sciences. So why do we need physician leaders in digital technology? Why should we not leave it to the technologists and to the Elon Musks of this world to provide us with the vision of where we head with AI and where we head, what the technology could bring us? And I think it's very well accepted in a more medical basic science that we need physicians also to guide the process, to provide the priorities, to be part of this process, and have clinician scientists that both work in a lab and conduct experiments, and also work at a patient bed, and really have this bench to bedside to bed and an entire circle and cycle multiple times to provide medical innovation. And I think we need a similar thing for digital technology, and become also knowledgeable and experts in our field, but also partially in the technology, so to an extent that we understand what is going on, and we can provide a vision. And I want to come back to the first proverb, and I looked that up. It's by Pliny of the Elder, and Pliny of the Elder was a painter, and he had the habit of standing behind the painting, listening to the people talking about the painting, and so happens to come a cobbler and judging that the shoe was not painted right. And that's where he got his input from. And the question is now, as physicians, should we be the cobbler and providing only the input and saying let's do this, maybe try this, but leave the vision to the technologists, or should we become more of the painters and paint the pictures for where we head with AI, what we use technology for, how we can make it solve real world problems that we see at the patient bed, instead of have very fancy technology that could solve all sorts of problems, but doesn't solve the problems that we need to be solved as physicians. So I think we need to allow ourselves to become uncomfortable and go into regions and areas where we're not trained for, and ask for the training that we need to become experts also in the field of technology and in the field of leadership. And become real provider leaders, and help provide the vision for the future generations. Thank you.
Thanks, Samuel. We also have Andrew, for personal reasons, who is joining us digitally. Let's see what he has to say.
As you have heard from my colleagues, we face a number of challenges in achieving an equitable future where technology does not hinder, but rather empowers clinicians to provide better patient care. Toward this aim, I challenge myself and other young physicians to not only improve digital health literacy within the healthcare community and for our patients, but also to continuously advocate that physicians have a seat at the table in the development, use, and monitoring of digital technologies designed for patient care. We must ensure that physicians have a voice in this ever-evolving conversation around digital health. Thank you.
And with that, I'd like to open the floor for any comments or questions. I saw a hand go up first on my left near the camera.
Thank you so much. My name is Dr. Ispa Alumba. I work for Amref Health Africa as well. My colleague was just here with us. In another life, I was a medical doctor, and now I work in the policy space. And so it's really great to hear the interventions that all of you have delivered. I just wanted to ask, from now a policy perspective and sitting down often with ministers of health and also presidents, when we're looking at some of the interventions that we see as digital health innovations, one of the biggest challenges we have is scaling up those innovations, especially within the African context, applicable innovation. So I just wanted to find out from all of you, what have you found have been the best ingredients for scalable innovations, particularly to accelerate the ability of healthcare workers to deliver better care? Thank you.
Any takers?
Maybe I take this. I think there's even this term for it, pilotitis, where we have a lot of pilot projects. They seem to go well, but then they don't scale. So the question is, do they really go well, and do we have the right metrics to measure that? And I think a lot has to be done in the evaluation and really the science of studying digital innovation in the health space. And rigorous, we believe in a scientific method for so many things, right? We believe in a scientific method to guide us with new drugs. And we should also equally believe in a scientific methodology to provide us with the right solutions in the digital health space. But in a digital, suddenly when there's an app, suddenly like the user number is a great metric. And it's not, and it doesn't tell us a lot, and it doesn't tell us anything about the health outcomes that introducing this application or the solution or whatever it might be has achieved. So I think we should call for more evaluation and really rigorous scientific evaluation of these solutions and find the right one to scale. And then I think my second point would be that there is a right and wrong of building and introducing digital technology. So what we hear a lot from one space is that digital technology is only a conducer to something that would happen anyway. It's only a tool, and that is right. But there's also a right way and a wrong way to build a tool and make it adaptable or fitting for a certain context. And I think finding these right tools built in the right way and for the right context and implemented in the right way needs a lot of science, implementation science, design studies, but also outcome analyses that has to be done, and it's work that needs to be done, and we should take the effort and do it.
Any further questions? Don't see any hands. Okay.
So thank you very much to everybody of you, and especially thank you for all these great company and colleagues. We spent very good time together. We had an amazing experience. We arrived here from all the corners on the world with several ideas of what we should have expected. But I think that what we have lived in this day has been amazing. And thank you for the InterAcademy Partnership for doing it, for join us this great experience. And thank you for the support, the questions, and to be committed as all of us for a better healthcare in the future. So thank you very much.